three different case scenarios of fetal growth and Doppler combination. Case 1, the GA by dating scan is 36 weeks. Previous growth scans were corresponding to her gestational age. Currently, her growth scan, the abdominal circumference at 6th percentile and fetal weight at 8th percentile. That is, both abdominal circumference and fetal weight are less than 10th percentile, like her 9 centimeter. So what is the diagnosis here? When the abdominal circumference and fetal weight falls below 10th percentile, there are two possibilities. One is fetal growth retardation. The next is small for GA fetus, small for gestational age. Here the Doppler provided are the umbilical artery Doppler, which has absent end diastolic flow, MCA Doppler with increased end diastolic flow. When there is fetal hypoxia, there will be cerebral vasodilatation, the brain sparing changes, which will increase the flow to the middle cerebral artery and will have low resistive index in MCA. So the Doppler here is abnormal, and the EAC and EFW less than 10th percentile, it is FGR, and this is stage 2 FGR because we have absent end diastolic flow. And since it is at 36 weeks, it is late onset stage 2 FGR. What other parameters are required to predict the time of delivery? We have to do fetal biophysical profile. That includes AFI, fetal tone, breathing, body movements, and we have to look for other Doppler parameters of ductus venosus, umbilical vein, aortic isthmus and all. This is a next case scenario, the similar history. AC and EFW are less than 10th percentile, but the Doppler here is normal. Normal umbilical artery Doppler and normal MCA Doppler. Now we call this as small for gestational age fetus. This is not FGR. Now case 3, here we have GA at 31 weeks and AC and EFW are less than 3rd percentile and normal Doppler. Though the Doppler is normal, since AC and fetal weight falls less than 3rd percentile, it is FGR. When AC or EFW less than 3rd percentile, it is a solitary criteria to call it as FGR. But when it falls between 3rd to 10th percentile, we will have dilemma between if it is FGR or SGA. So we will have to look for abnormal Doppler. The abnormal Doppler mentioned is in early FGR, that is before 32 weeks, we have to look for umbilical artery and uterine artery PI. If they are more than 95th percentile, it is abnormal Doppler. In late onset, uterine artery will be of less use. We have to look for the ratio of RI between MCA and umbilical artery, that is the CPR, cerebroplacental ratio. If it is less than 5th percentile, this is the abnormal Doppler. When the AC or EFW falls between 3rd to 10th percentile, we have to take the Doppler parameters to differentiate FGR and SGA. So this is the normal umbilical artery Doppler. Here this is absent end diastolic flow, this is reversed end diastolic flow. Regarding the timing of delivery, if there is elevated Doppler parameters, the biophysical profile performed weekly and delivery anytime after 36 weeks. When we have absent end diastolic flow, delivery anytime after 34 weeks and reversed end diastolic flow anytime after 32 weeks. Regarding the stages, in stage 1 FGR, we will have abnormal umbilical and MCA PA. In stage 2, absent end diastolic flow or reversed end diastolic flow as in our first case. And stage 3, reversal of flow in ductus venosus, a tricuspid regurgitation. This is case 2. Here we have a twin pregnancy. So what is this type of twin? This is single placenta and thin intraamniotic membrane. It is monochorionic diamniotic, MCDA type of twin. And what is the abnormality seen here? Twin A has less liker, oligohydramnios, and B has comparatively increased liker. The oligohydramnios, polyhydramnios combination with MCDA type of twin, it is twin-to-twin transfusion syndrome. The staging name is Quintero staging. The fetal intervention that can help is laser coagulation of the interplacental anastomosis. Actually, the twin-to-twin transfusion is there will be abnormal anastomotic supply between both the twins when they have a single placenta. When they share a single placenta, the abnormal supply will have less vasculature to one of the twin. That twin will have oligohydramnias. The other twin with increased vascular supply will have polyhydramnias. The other common complication with MCDA twin are the TES, twin embolization syndrome, the trap twin reverse arterial perfusion syndrome, and placental insertion problems like marginal placenta and filamentous insertion of the cord. The trap, here there will be a twin with acardiac twin. The twin will have a morphologically anomalous heart that will have received from the coexisting twin. In twin embolization syndrome, there will be death of co-twin and the thromboplastic agents will transfer from the dead twin into the live twin. To differentiate monochorionic and dichorionic, here we have the lambda sign. There will be intervening placental tissue into the intraamniotic membrane. Twin peak sign or lambda sign, this is DCDA twin, dichorionic, diamniotic. Here we have single placenta, thin intraamniotic membrane and no intervening placental tissue. It is monochorionic, diamniotic. And this is again MCDA twin. One of the fetus is having fetal hydrops. Here ductus venosus we have a reversal of A wave. This is again twin to twin transfusion syndrome in monochorionic diamniotic. This comes under stage 4. Stage 1 there will be oligohydramnios polyhydramnios combination as we saw in our first case. Due to oligohydramnios the twin will have oliguria, so the bladder will not be visible in stage 2. And stage 3 abnormal Doppler, stage 4 hydrops, stage 5 IUD. In this stage there develops the twin embolization syndrome where the dead twin will transfer its thromboplastic agents into the live twin. Now what is this view? What are the lines A, B and C? This view is the mid-sagittal view of the fetus space and upper thorax zoomed for the measurement of nuchal translucency. This is the nuchal translucency we measure. But what are these three lines? Line A, B and C. The line A is along the sphenoid ridge, the posterior border of the sphenoid ridge. B along the anterior border of the fourth ventricle. C along the occipital bone. So what is the structure lying between the sphenoid bone and the fourth ventricle? It is a brainstem. So the distance AB denotes a brainstem and BC denotes the brainstem occipit distance. Normally the brainstem will be smaller compared to the brainstem occipit distance. So the BS-BSO ratio will be less than 1 in normal cases. But in this case we have apparent widening of the brainstem compared to the brainstem occipit distance. So the ratio of BS-BSO will be less than 1 in normal fetus. When there is spina bifida or any open neural tube defect, there will be leakage of CSF. So the posterior space, CSF space will reduce and there will be apparent widening of the brainstem. This is the intracranial translucency or the fourth ventricle. And the next case, the patient presented with abdominal cramps, no vaginal bleeding, CRL 2.9 centimeter without fetal cardiac activity. What is the arrow pointing to? Here CRL when it crosses 7 mm without cardiac activity, it is missed abortion or early embryonic demise. And what is this structure is, we have a polypoidal soft tissue structure with echogenicum and central relatively hypoechoic region. It is chorionic bump. In first trimester, the association of chorionic bump is increased risk of first trimester miscarriage. Now we have a third trimester primary mother with bleeding PV. This is the placenta, and posterior to the placenta, that is in the retroplacental region, we have hypoechoic collection. This is retroplacental hematoma. It is a case of abruption. There are 3 types of abruption and the common one is the marginal type. And the complications with abruption will be IUGR and fetal demise. The differential, sometimes myometrial contraction, the fibroids, intraplacental lakes may mimic abruption. The other features for abruption include separation of placental edge or thick placenta, thick retroplacental myometrium. When there is bleeding into the amniotic cavity, we will have intraamniotic echoes. And if the fetus swallows the amniotic hemorrhage, there will be echoes in the fetal stomach. In case of twin pregnancy, in abruption, in the intermembranous membrane, there will be clot. This is placental lake. It will be relatively well defined within the substance of placenta. And the common cause of first and second trimester bleeding is this subchorionic hemorrhage. There will be blood collection between the uterine wall and the chorion. Now we have an image of fetal MRI. What is the sequence and plane of MRI? What is the standard sequence for fetal MRI? This is sagittal T2. The standard sequence is single shot fast spin echo because that will reduce the fetal maternal motion artifacts. Here we are focusing on the placenta. The diagnosis is placenta accreta. We have a bulging placenta and almost there is no retroplacental dark zone, an abnormal T2 intraplacental dark bands, an abnormal retroplacental flow voids, and the bladder is compressed and placenta is seemingly invading the bladder wall. So this is a case of placenta accreta. And this is ultrasound image of accreta. We have abnormal vasculature in the retroplacental myometrium. There is a loss of myometrium between the bladder and the placenta. Again, another fetal MRI, we have thick placenta with diffuse cystic changes. The ultrasound also shows thick placenta with the multiple cystic areas, and we have a live fetus. So the differentials, there are three common possibilities. First, it can be placental abnormality like chorioangioma or placental mesenchymal dysplasia. The other possibility, it can be a twin pregnancy with a single live fetus and coexisting molar pregnancy. So what will be the next evaluation? The conclusive evaluation will be doing the tissue analysis. The chorionic villus sampling or amniocentesis will be the diagnostic. But other serum parameters like beta HCG, AFP can also be done because beta HCG levels will be very high in coexisting molar pregnancy. In placental mesenchymal dysplasia, the AFP levels will relatively be high, and there are high chance of IUG or IUD or preterm delivery. This again fetal MRI, we have the fetal brain. There is a cystic structure in the posterior fossa, and the cerebellum is small atrophic. It is a case of Dandy-Walker malformation. Differentials will be Dandy-Walker variant, posterior fossa arachnoid cyst, megacisterna magna. Here we have associated neural tube defect, posterior defect in the spine. Now we have images of the fetal brain and spine. Fetal brain, we can see relatively dolichocephalic skull, that is elongated skull with bifrontal indentation. What is the name? This lemon sign. We'll have bifrontal indentation, and the cerebellum posteriorly is severely compressed and loss of CSF space here. And in spine we can see open neural tube defect and a myelomeningocele. So this combination, it is Arnold-Chiari type 2 malformation. Next we have images of fetal thorax. Here we can see the fetus left hemithorax is occupied by a mixed echogenic mass, predominantly hyperechoic, multiple cystic spaces. There is gross mediastinal shift to right, and the right lung is severely compressed. The coronal image, we can see there is intact diaphragm, and the small stomach bubble is seen on the left side, clearly beneath the diaphragm. Whenever we see cystic mass in the fetal thorax, in ultrasound, the three common differentials will be CPAM, congenital adenomatide malformation, pulmonary adenomatide malformation, congenital diaphragmatic hernia, or sequestration. These three are the common possibilities. So when we find a echogenic mass, what will be the next evaluation? We have to look for the integrity of the fetal diaphragm, look for the stomach bubble, look for polyhydramnios association, also look for abnormal vascularity. Because in case of sequestration, we will have abnormal supply from the thoracic aorta supplying the sequestered lung. This is a case of CPAM because we have mixed echogenic mass, intact diaphragm, and the prognostic indicator of CPAM is the size of the lesion. We have to measure the volume of the CPAM in two planes, and the volume is calculated and the ratio is taken with the head circumference. If the volume is more than 1.6 or CPAM has a very large dominant cyst, there is risk of developing fetal hydrops and it is of poor prognosis. This is next image of fetal thorax. We can see the stomach bubble and heart in same transverse plane with the gross mediastinal shift. So this is a case of congenital diaphragmatic hernia, and here the prognostic indicator is lung head ratio. The lung mentioned here is the area of the contralateral lung. The area of the contralateral lung is taken and the ratio to head circumference is measured. And if the ratio is more than 45%, it is mild CDH. And what is FETO? It is the attempted fetal therapy. It is a novel technique. This FETO is endoscopic occlusion of the fetus trachea. A balloon is inserted into the fetus trachea and it is caused tracheal occlusion. The reason is when there is CDH, the main mortality and morbidity is due to pulmonary hypoplasia. When we occlude the trachea like this, the lung will retain its own secretions because the secretions will come out of the trachea only to the amniotic fluid. When the lung holds its own secretion, the risk of pulmonary hypoplasia will be decreased. So the morbidity and mortality due to pulmonary hypoplasia will be reduced. This is the FETO. The balloon is inserted at 26 weeks and it is removed after 34 weeks and it is kept inflated in between period. Now we have fetal echo. When we are provided with fetal echo images, we have to know the fetal echo views. This is actually a 4-chamber view showing a perimembranous ventricular septal defect. Here we can see overriding of aorta. This is the interventricular septum. This is overriding of aorta. This combination, it is tetralogy of Fallot. And the sign associated here is a question mark sign. This produces a question mark like appearance, the overriding aorta, the aortic outlet. So normally the fetal echo views is a 4-chamber view. This is the LVOT, left ventricular outflow tract, where I have the septo-aortic continuity. RVOT, we have bifurcation of the pulmonary arteries, and this is 3-vessel view, the pulmonary artery, aorta, and SVC. The pulmonary artery will be slightly larger or equal to the size of aorta. The size will be in descending order. This is a normal septo-aortic continuity. Here we have a breach and overriding aorta. This is a question mark like appearance. This is a case with a large right atrium and dysplastic tricuspid valve. The diagnosis is Epstein's anomaly. Here we have parallel outflow tracts. This is a case of TGA, transposition of great arteries. Normally the outflow tracts will be crossing over. So next fetal echo image. Here name the views. What is the ratio and what is the significance of ratio? What is the diagnosis? Associations of other cardiac anomalies, and what is a common associated chromosomal abnormality. So the views here, it is the sagittal view of fetal aortic arch, 4-chamber view. This is a 3-vessel trachea view. In the aortic arch view, we can see narrowing of the isthmus, and there is post-ductal dilatation of the descending aorta. Here also we can see the narrow isthmus and widened ductus. This ratio is the ID ratio, ratio of isthmus to ductus. And this is apparently normal 4-chamber view. The diagnosis is coarctation of aorta. In coarctation of aorta, the isthmus ductal ratio, this is the isthmus and this is the ductus. Narrower the isthmus, poorer the prognosis. It is a predictor of postnatal surgery. And common associations will be bicuspid aortic valve stenosis, large VSD, mitral stenosis, and common chromosomal abnormality will be Turner's syndrome. And what is the abnormality, what is the grading, and what are all the association? Here the abnormalities, we have echogenic bowel. Always echogenicity should be compared with the adjacent iliac crest, and it is grading is also according to it. Echogenicity less than iliac crest, equal to or more than iliac crest. There are 3 grades. Common association of echogenic bowel will be trisomies, cystic fibrosis, and infections like CMV. Now name the view. What is the structure measured? What is the abnormality and criteria for it? What other structures to look for? Here we have a large urinary bladder. This is the enlarged fetal urinary bladder. To confirm if it is bladder, we have to turn on the Doppler and look for umbilical arteries on either side of the bladder. And the bladder size is abnormal, that is bladder size more or equal to 7 mm between 11 weeks to 13 weeks 6 days. That is during early NT scan, if the bladder size more than 7 mm, it is megacystis. If we see megacystis, next we have to look for the kidneys to look for the extent of obstructive uropathy, megacystis, megaureter syndrome. Look for the bowel to rule out megacystis microcolon syndrome. Look for the integrity of abdominal wall to rule out the prune belly syndrome. And if the bladder size is between 7 to 15 mm, there is high risk for trisomies. If the bladder size is more than 15 mm, it is highly indicative of obstructive uropathy. Again, the next case we have enlarged bladder, but the end there is a narrowing and a dilatation appearing like a keyhole. This is actually the posterior urethral dilatation, and this is the bladder. And we also have hydronephrosis of one of the fetal kidneys. So this diagnosis is posterior urethral valve, and classification is Young's classification. There are 3 types. And the fetal therapy here, what can be done is the vesicoamniotic shunt. A shunt can be created between the bladder and the adjacent amniotic fluid. Because if we leave the bladder be obstructed like this, the bladder will get over distended and there will be oliguria or anuria. With the anuria, there will be development of oligohydramnias. When there is oligohydramnias, again there will be growth retardation, pulmonary hypoplasia. So in order to vent it out, we should also create a shunt between the fetal bladder and the amniotic fluid. If it is left like that, there are high chance of renal dysplasia. Now we will see few chromosomal syndromes. We have combination of images. First image, fetal brain. What is abnormality seen here? We can see the posterior fox is intact, the anterior fox is not seen, the cavum septum pellucidum is not seen. Here there is midline fusion. It is lobar type of holoprosencephaly. And we have polycystic kidney. One of the kidney is normal, the other kidney is polycystic. We have polydactyly, increased number of digits. This is rocker bottom foot, and we have a bilateral cleft lip. So altogether, this is Patau syndrome. It is trisomy 13. Patau syndrome, mainly there will be midline abnormalities. The lobar ovuloprosencephaly, the cleft lips are more in favor of Patau syndrome. In Edwards syndrome, we'll have the strawberry shaped skull. It is non-specific, but it is highly associated with Edwards syndrome. And the difference is in lemon skull, there will be a mild dolichocephaly, that is elongated skull with bifrontal indentation. But in strawberry skull, the skull will be small, the brachycephaly with a pointing frontal apex, and there is a flat occiput. This is strawberry skull. With bilateral choroid plexuses, clenched fist, rocker bottom foot are also associated with Edwards syndrome. Down syndrome, in early trimester scans, during NT scan, there will be increased nuchal translucency, reversal of flow in ductus venosus, tricuspid regurgitation. The common cardiac defect in Down syndrome is endocardial cushion defect. That is the combined atrioventricular septal defect, absence of the crus. And early stages in Down syndrome will have echogenic bowel, fetal pilectasias, double bubble sign, duodenal atresia. These are the soft markers for the Down syndrome. And Turner syndrome, we'll have fetal eye drops, and disproportionate to the eye drops, there will be massive cystic hygroma. The cystic hygroma will be so large, multicystic, that is more pathognomic of Turner syndrome. Again, as I said earlier, coarctation of aorta is commonly associated with Turner syndrome. So what is this view and what is the abnormality? Here we have the mid-sagittal view of the fetal face. Normally the nasal bone, the maxilla, mandible should lie in the same line. Here we have receding jaw. There is the retrognathia or micrognathia, and this is commonly associated with the Pierre-Robin syndrome or other trisomies. To confirm if it is a retrognathia, we have angle, that is, angle is drawn between the frontal nasal junction and angle along the mentum, the frontonasal angle, and jaw index, the AP and transverse diameter of the jaw are calculated, and this is to tell if it is a retrognathia. And in Pierre-Robin syndrome, we'll have triad of retrognathia, posterior cleft palate, and polyhydramnias. So this is the normal image. We have nasal bone, the maxilla, mandible lying on the same line, and here we have a cleft palate, posterior cleft palate. Finally, we'll say 2-3 procedures. What is this procedure? What is the ideal gestational age to perform it, and what are the indications, what are the complications? This is chorionic villus sampling. The needle is entering into the placenta. This is the transvaginal approach. This is transabdominal approach. The tissue taken from the placenta, it is mainly done to rule out the aneuploidies. And the complications will be missed abortion, infection, premature rupture of membranes, limb reduction defects. The CVS is performed between 10 to 14 weeks, that is early weeks. When it crosses 15 weeks, the recommended procedure is amniocentesis. When we detect any anomaly during the anomaly scan, next we have to perform amniocentesis to rule out the aneuploidies. Here the amniotic fluid is taken for the analysis. In CVS, we take the sample of the placenta. In amniocentesis, we take the amniotic fluid. This is a final slide. What is the procedure? What is the instrument and drug used here? What is the site of needle placement, and what are all the complications? Here the procedure is embryo reduction, selective embryo reduction, intrauterine embryo reduction. When there are multiple pregnancies like triplets, quadruplets, we can reduce the desired number of fetus, and the instrument used is Cook's embryo reduction needle and cannula, and the drug is KCl, potassium chloride. The site of needle placement is directly into the fetal thorax, directly into the site of cardiac pulsation. This is mainly because the KCl will produce immediate cardiac arrest. So when injected directly into the heart, there will be immediate cardiac arrest. And the complication, there can be IUGR, missed abortion, or infection to the other fetus, and there can also be rupture of membranes. Thank you.
Thank you, ma'am, for such an enlightening and comprehensive session. I now request Dr. Saranya ma'am to felicitate Dr. Alamelu ma'am. Next, I invite our notable and enthusiastic alumnus, Dr. Atul Sir, Consultant Radiologist, Ma Peslios Medical Mission Hospital, Kochi.